online course on research methodology. Today, primarily the program will be under these headings: introduction about the speakers, Dr. Manjula, Dr. Sanjay Adla, Dr. Arvind Ganpule, and Dr. Pankaj Maheshwari. The introduction of Dr. Manjula will be given by Dr. Arun Chawla, sir. After that, we'll continue the program. If you have any doubts, please feel free to put in the chat box so that we will take them up. Sir, Dr. Arun Chawla, sir, thank you once again for making this possible with your effort. Please introduce Dr. Manjula, sir, please.
Thank you, Dr. Chandramohan, Honorary Secretary, Association of Southern Urology. And welcome to everybody who has joined. We all know that this is the first online event in the field of the basic course on research methodology, which has become actually a part and parcel of the curriculum under the NMC. All the residents who are doing MCH have to clear the SWAM course by NMC or some sort of biostatic course to be eligible to write the MCH exam. You know that last year we had a very esteemed faculty, Dr. Danish, who has extensively taken these courses. For a change, we have started with a different initiative to have a basic course and advanced course. This basic course will run for 4 to 6 hours, which will have today's online class and another class on systematic review and meta-analysis, to be followed by advanced course in the month of April and May. Now, this just how the course started. This is a brainchild of two of our esteemed colleagues, Dr. Jinil and Dr. Surya Prakash. And with the able help of Dr. Chandramohan Vaddi, who has been a secretary at that point, this idea came into practice. And this is how we are here for this year's first basic course on research methodology. I have a great pleasure in introducing today's expert faculty, Dr. Manjula. But at the same time, just introducing the expert faculty, Dr. Arvind Ganpule and Dr. Pankaj. Dr. Sanjay Adla has excused himself. He is busy in some program. Dr. Manjula is Associate Professor in the Department of Community Medicine, Kasturba Medical College, Manipur. Just briefly to say, she is expert and master of this field. Why? Because she is a PhD in this subject, and she was awarded a doctorate from Mangalore University for her work in statistical model in epidemiological study. You can just imagine that whose core subject, core passion is the statistics, how good she will be. We did speak to her to keep her talk focused to the urology residents, and she had done her best to keep her talk focused. She will be talking about, as you know, we talk about different design, whether we should do case studies or whether we should do a observation study, what type of study we should do, number of studies, randomized. She'll be talking into all these things with some stress on how you should initiate, what question you should have in mind, what type of objectives and hypotheses you should have before starting the study. And as you know, when we advance to the more deeper, we get always confused with the statistical method. And for a clinician, it becomes boring. For residents, it becomes extremely boring. But she will take to this area a little with simplicity and what you can say in the basic level, so that you understand what type of statistical method are to be used for different type of study. Added to all this will be the quality comments from the experts. Both are expert in this field. Dr. Arvind Ganpule has been the ex-associate editor of Indian Journal of Urology. Dr. Pankaj Maheshwari is the current editor of Indian Journal of Urology. Both have been associated with a number of international urology organizations and journals. And both have within the multiple time they have got best reviewer awards for the reviewing different articles in not only the Indian journal but as well as the international journals. With this brief word, I throw open the today's program to invite again Dr. Manjula to start your presentation.
Thank you, sir. Thank you, sir. Thank you, Dr. Manjula. 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 Thank you, sir.
Dr. Manjula?
Yes. Am I audible enough?
Yes, madam.
Dr. Manjula?
We are able to see your slides, please.
Yes. May I start?
Madam, little louder.
Yeah, please, madam.
Now, am I audible?
Ma'am, your voice is not clear.
Now, am I audible, sir?
A little connectivity problem, madam. Little breaking of the voice is coming. Otherwise, okay. You start, madam. It will adjust automatically after 1 or 2 minutes.
Good evening, one and all. First and foremost, let me
No,
thank sir.
no, Dr. Manjula, no, it's not clear. It's not good. If you can just see that anything issues with the laptop or anything, or you can just connect from my computer.
Now, am I audible?
Ma'am, slides are there, but your voice is not clear. Arvind, is my voice clear?
Yes, sir. Your voice is clear. Madam also voice is also okay. It will
Your voice
adjust,
is
sir.
clear.
No, madam voice is not clearly audible to me. I don't know. Means how's your end?
No, sir. I am. It's audible, but a little breaking is there.
Yeah.
You continue, madam. We'll see.
Madam is in my next to my room only. What I'll suggest is to come here and present from my end. Sorry, Chandramohan, just 1 minute you give us. We're setting the things again.
No problem, sir. Please take time.
You can really close to the computer if it's okay. Yes, yes. Okay, take your time. And you can say hello if they're audible, we can.
Good evening. Am I audible enough?
One by zero. One
One of you close the two connections will give reverberation.
Doing that.
Good evening. Am I audible enough?
No, madam, there is a significant echo. I think there are two connections on.
This you can close it and you speak from here. Here. This is here, you can stop here. Yeah. Okay, now you see that.
Good evening.
Better.
Yes. Thank you, sir. So good evening, one and all. Thank you, sir, for that wonderful introduction of mine. So first and foremost, I wish to thank Dr. Rajendra Nirli, the President, Dr. Arun Chawla, the Chairman, Dr. Chandramohan Baddi, the Honorary Secretary, Association of Southern Urologists, for giving me this opportunity to be a speaker for today's session. I'm truly grateful for inviting me to speak in the midst of the enthusiastic as well as the research-oriented audience. I would also wish to thank Dr. Sanjay Adla, Dr. Arvind Ganpule, and Dr. Pankaj Maheshwari for agreeing to be my expert, for giving the expert comments. So to start with my session on research methodology, first, to start with research. So in simple terms, research implies the search for knowledge. So if I were to precisely define it, research is to do with the scientific as well as systematic search for information on any specific topic. So I would prefer to call it as an art of scientific investigation because it involves various phases, such as defining a problem, formulating a hypothesis, collection of facts, analysis, drawing conclusions, or finding solutions to a given problem. So quite often we come across the terms such as research methods and research methodology. So what are these two terms? So these two terms are closely related, but have conceptually different meanings. So research methods are the techniques that the researcher makes use of for conducting research work. So the researcher may make use of various tools, the procedures used, which would be for the collection as well as analysis of data. The researcher may make use of some surgical instruments or surgical procedures, or make use of some structured questionnaire, maybe the International Prostate Symptom Score, or the researcher may also make use of various statistical tools, such as for analysis, it could be the chi-square test, or it could be the logistic regression, etc. So the various techniques that the researcher makes use of is called as research methods. Whereas when it comes to research methodology, it is the systematically solving of a research problem. So the researcher should have an idea on how to scientifically conduct a research work and what are the various steps involved in doing a research study. So the researcher in this case should not only know as to what are the various tools that has to be used or what are the procedures that can be adopted, but at the same time, the researcher should have an idea as to why a particular procedure or why a particular tool was adopted, and if it had to be adopted, what is the logic behind using the tool? What were the assumptions that were used to adopt that particular test. So in this case, the researcher will have to build up a framework or a blueprint for design to carry out his research, and this is known as research methodology. So the first step in any research problem is, or the first step in any research process is defining the research problem. So when it comes to a researcher, lots of ideas will be running up in the minds of the researcher, maybe through through ideas that pop up during clinical practice or by reading a recently published publication, etc. So the researcher will have to narrow down, will have to consolidate all these ideas into so-called focused, clinically relevant, and achievable research. So the research question has to lead to results which can have a positive impact on the patient. Maybe the researcher may try to bridge the gap by, say, for example, developing new biomarkers or diagnostics, or try to improve the results which has already been established by others, or identify novel treatments for a particular treatment. So one of the important steps in research, planning research, is to frame a research question. And this research question should be clear and precise for the reason, such as this research question is the one which would help to develop the hypothesis, as well as the aims and objectives, as well as the methodology. And of course, using the research question, the title to the study can be framed. So the title is basically the snapshot to the research, wherein other readers who go through this research article will get an idea through the title, which is precise and concise, as to whether this study is within their interest or not. And of course, the third reason for having a good research question is a research question is required basically to attract or to gain research fundings. 1 minute, sir. There has been some issues. So when a research, am I audible?
Yes, ma'am. Yes, ma'am.
Yes, thank you, sir. Sorry for the interruption. So when a research question is framed, we may use the mnemonic PICO, so where PICO stands for population, intervention, comparison, as well as outcome. So P would stand for those who are the patients to be studied, I is the intervention or the drug to be administered, and C is the usual standard of care or the current best practice, and O is the outcome, and the researcher should mention as to how the researcher will go about taking into consideration the outcome measures and how is the researcher going to measure the outcome measure. So once the researcher decides on the PICO framework, it is quite essential to know how good is this PICO framework that has been set up and what are the whether it possesses the characteristics of a good study. So to know that, another mnemonic can be used, that is to make use of the finer criteria in terms of feasible, interesting, novel, ethical, as well as relevance. So in feasibility, we can consider that any research question would be feasible in terms of the number of patients or the samples or the time or the resources that are required to conduct a study. Interesting as to whether this research question is of interest to the researcher himself as well as to the scientific and clinical community, and whether this research finding could lead to new findings, whether it is possible to answer the research question in an ethical manner, and whether it could provide improved patient care to with regard to the treatment that's been adopted. So here we have a simple example, that is, among men with acute urinary retention, does alpha blocker treatment improve trial success compared to that of placebo? Now we need to decide as to whether this research question is focused and whether it meets the PICO criteria. So looking into it, we can see that it has got almost all the characteristics of the PICO framework, wherein we have the population, that is the men with acute urinary retention. Intervention over here is the alpha blocker treatment, and the comparator that has been considered over here is the placebo, and the outcome is to improve voiding trial success. Of course, the PICO framework that has been set for this research question is feasible enough because it's been known that there are enough number of cases that would be available, and also the intervention is accessible. It seems interesting because it could reduce hospital admissions to the patients. And of course, it avoids surgery as well as prolonged catheterization to the patients as well. When it comes to novelty, maybe the researcher can think of considering patients with various comorbidities and could see how the results would vary. And of course, it is ethical because alpha blockers are the standard therapy. So if you were to consider another example, that is among patients with 10 to 15 proximal urethral stones, does urethroskopy compared to shockwave lithotherapy result in a high stone-free rate at 3 months? This too has been framed as per the PICO framework, where P represents the patients with 10 to 15 proximal urethral stone. I is the urethroskopy, that is the intervention that has been used over here. C, the comparator, is the shockwave lithotripsy. And O is the outcome, that is achieving stone-free rate. And we have an additional component over here, which is considered at 3 months. Of course, we have another example, that is among men with low-risk prostate cancer, does active surveillance result in similar 10-year mortality rates compared to radical prostatectomy? So here too, we have the characteristics which fits into the PICO framework. So coming to the study design. The study designs range from the simple case control to the RCTs. So study designs are broadly classified as the observational study as well as experimental study, wherein in an experimental study, the researcher would intervene, would provide a treatment, and then would be interested to know the effect of the treatment on the natural history of the disease. Whereas in an observational study, the researcher does not intervene and tries to collect information with regard to the exposure as well as the outcome at the same point in time. So we have the hierarchy of study designs wherein we have the randomized controlled trials providing evidence on causation on the topmost, followed by non-randomized trials and then the observational studies. So if you were to consider an example, that is among women with uncomplicated UTI, does a 3-day course of ciprofloxacin achieve similar cure rates compared to that of a 7-day course? So this seems more like an RCT. So what are the various steps in an RCT? So the researcher will have to define the study objective. It could be a primary objective over here, that is to compare the clinical cure rates between the 3-day and a 7-day ciprofloxacin therapy among women with uncomplicated UTI. The next step would be to develop the eligibility criteria and have the inclusion as well as the exclusion criteria set up as per the objective of the study. Of course, the sample size needs to be calculated based on the expected number of individuals to be considered for the study on the basis of the outcomes expected with some specified part as well as the level of significance. Then randomization can be conducted. Allocation concealment needs to be carried out. Blinding may be done. Either a single blinding, double blinding, or a triple blinding may be considered, wherein in a single blinding, it would be only the study participants who would be unaware of the treatment group that they are receiving, whereas in a double blinded, both the participants as well as the outcome assessor will be blinded. In a triple blinded, both all three, that is the participants, the outcome assessor, as well as the statistical expert involved, would also be blinded. And then check for the intervention protocol and ensure it's standardized, it's dosage, same instructions, and adherence monitoring. And finally, the outcome assessment is done with regard to comparison of the cure rates. Next, coming to the observational studies, wherein we have the cross-sectional studies, which is like viewing the snapshot of the population. So the researcher in this case tries to evaluate both the risk factors as well as the disease outcomes simultaneously. And of course, it's used for generating hypotheses. We have an example in relation to urine pH and kidney stone, wherein when the patient comes to the OPD, maybe on the same day, the ultrasound CT would confirm stone status, and also the urine sample will be collected to measure the urine pH. So both these factors are assessed on the same day. So here we see that it is possible to test whether there is any association between these two factors, but one will not be in a position to find any causation because we cannot determine whether acidic urine preceded the stone formation or the other way around. So the advantages of a cross-sectional study is that even though causality cannot be proven, one can identify the possible risk factors. And these possible risk factors can be used in future to generate hypotheses and can also be used in prospective cohort study as well as interventional studies. Now, in case control studies, what we have is we have the cases, we have the controls. The cases are the diseased individuals and the controls are the comparable to the cases but without the disease. And then we look into the past exposure amongst the cases as well as the controls and see how many of the cases were exposed to the risk factor under investigation and how many of the controls were exposed to the exposure under investigation. So these case control studies are usually called as retrospective studies, where we proceed backwards from the effect to the cause. The exposure as well as the outcome have already occurred before the start of the study, and we use a control group to make a comparison with the case. So, of course, the steps in a case control study would be the selection of the cases and the controls, matching needs to be done, the measurement of the exposure has to be done, and analysis may be carried out in terms of estimation of risk as well as odds ratio. So, where do we select the cases from? So, the cases can be selected either from the community or it can be selected from the hospitals. So, when it comes to hospitals, it can either be a single hospital or a network of hospitals within a defined geographical area at a specified period of time. Either all the cases may be considered or a random sample may be selected. Similarly, the controls may be selected either from the hospitals, or it could be a relative or a neighborhood control, or from the general population. And of course, matching of the cases and the controls needs to be done, such as matching may be done with regard to age or gender, occupation, locality, or some other factors. But if too much of matching is done with regard to various variables, ultimately will be end up having no other factors left to find an association with the outcome. So the measurement of exposure can be done by means of interviews or questionnaires, or it could also be from the past records such as hospitals or employment records. And then the analysis can be carried out. If the odds ratio turns out to be 1, it implies that the exposure is not related to the disease. If it's greater than 1, it implies that the exposure is positively related to the disease, and less than 1 implies exposure is negatively related to the disease. So we have an example, which is an extract from the journal, wherein earlier, for screening, the digital rectal examination for prostate cancer mortality, the digital rectal screening was done, but now other techniques may be used. So to simplify the example, this example has been considered. So the cases and the controls may be defined as: the cases are the residents of a region who had prostate cancer listed as per the death certificates, and the controls were also selected from the same region having a medical record in the community. So when a case control study was conducted, the researcher came up with an odds ratio of 0.51, which indicates that the individuals who underwent screening had 49% lower odds of dying from prostate cancer compared to those who were not screened, suggesting that screening serves as a protective factor. So usually in a case control study, there is a possibility of having recall bias, and we are also subject to sampling bias as well, because it all depends on how the cases and the controls are being selected. Temporal relationships can sometimes be inferred but not directly observed. And of course, there exists the problem of recall bias. Now, when it comes to cohort study, we have a group of individuals, and amongst those group of individuals, we try to find out as to how many of them are exposed to a certain risk factor under investigation, how many of them are not exposed to the risk factor, follow them over time, and then find out as to how many amongst the exposed develop the disease and how many amongst the non-exposed develop the disease over a period of time. So initially, it is expected that all cohorts, or it should be that all cohorts must be free from the disease under investigations, and both groups must be comparable, and the diagnostic criteria to define an outcome should be clearly defined. So there are different types of cohorts, such as prospective cohort as well as the retrospective cohort. So if a researcher starts a study in 2026 pertaining to a particular topic of interest, then the researcher will follow up this cohort to see how many of them will be exposed to the risk factor under investigation, how many of them do not get exposed, and amongst them, how many of them develop the disease and how many of them do not develop the disease. So this would be a prospective cohort study. Whereas to make the task simpler, or to save some time or save some cost incurred that could have incurred, retrospective cohort study can be done by looking into the past history of the records and trying to find out the individuals who are exposed and non-exposed, who can then be followed up from the history that is from the past until they develop the disease amongst the exposed as well as non-exposed. So the steps of conducting the cohort study would be the selection of the study group, information on exposure has to be decided. So accordingly, the selection of the comparison group has to be done, followed up, finally, analysis has to be done. So the estimation of the risk could be the relative risk, the attributable risk, and the population attributable risk. So relative risk, if it turns out to be 1, it indicates that there is no association between the exposure and the outcome. Greater than 1 implies that there is positive association, and less than 1 suggests that there is negative association. So with the usage of the attributable risk, the researcher is trying to find out as to how much reduction in the incidence of a particular disease may be achieved if at all the exposure was eliminated. Whereas in the case of a population attributable risk, the researcher is trying to find out in a population, in case if some programs have been implemented, such as the elimination program with regard to, say, for example, the tobacco cessation program has been implemented in a particular district. Then, if that was implemented, then how much reduction in the incidence can be observed is what the population attributable risk would calculate. So the difference between the case control and a cohort study is that the case control, it proceeds backwards, that is from effect to cause, whereas a cohort study proceeds forward from cause to effect. It starts with the disease. The case control study, it starts with the disease, whereas a cohort study starts with the people who are exposed to the risk factor. And of course, in a cohort study, large number of study participants would be required who needs to be followed up for a long period of time. And of course, it would be very expensive to conduct a cohort study. As a case control study might yield quick results, and it's also suitable for rare diseases, and it is quite inexpensive. So coming to the statistical considerations, which is usually said to be the science of figures, which involves various phases such as collection of data, classification of data, presentation, analysis, and it also includes giving a conclusion or an interpretation to the data. So when it comes to the collection of data, the researcher should have an idea as to what is the source of data that the researcher intends to use for the study and which sampling techniques would be used to select the study participants. Once the collection is done, you have the raw data which needs to be transformed into something meaningful. Hence, classification and presentation of data is done. Analysis, as per the objective of the study, may be carried out using descriptive as well as inferential statistics. And finally, interpretation to the data. So under descriptive statistics, the researcher is trying to concise huge masses of data into one single number. Whereas in inferential statistics, the researcher tries to test the hypothesis based on the sample, come to a conclusion whether to accept or to reject the null hypothesis. So the source of data, as I've already mentioned, it could be the primary data or the secondary data, where the primary data is the first-hand data, which the researcher usually collects it in the form of interviews or questionnaires or through examination, observation, or investigation of the study participants. It could also be obtained from the medical records department of any hospital. It could also be collected from the hospital registers as well. Then the researcher once has an idea as to what is the source of data. Next, the researcher should decide as to what would be the optimum number of individuals to be considered for the study. It should never be a magical number, but the sample size has to be scientifically estimated. And accordingly, since it's not possible to consider all individuals from the entire population, it is a representative sample that needs to be taken from the population. And using the sample, we try to draw inference with regard to the whole population. Of course, there are various sampling techniques, probability as well as non-probability sampling techniques, wherein in a probability sampling, every individual of the population has an equal chance of occurring in the sample, and the researcher can decide on any one of those sampling techniques. When it is not possible to select a probability sampling, maybe a non-probability sampling could be adopted. So a simple one would be the simple random sampling, or otherwise, if it is not possible, maybe a non-random sampling technique could be adopted. And of course, when the researcher starts a study, it's quite essential that they need to have an idea as to what is the kind of data that they are handling. Is it a quantitative data or a qualitative data? And accordingly define the variable that varies from one individual to another, which is quantitative, which is measurable in nature. Whereas if the researcher is making use of some characteristics which cannot be measured, which cannot be given a unit of measurement, and it varies from one individual to another, then it is termed as an attribute. It's a blood group that can be called as an attribute, whereas when it comes to hemoglobin level, which is measurable, it's called as a variable because it varies from one individual to another. So the next important thing that the researcher should bear in mind is anything that looks like numbers are not capable of direct analysis. Such as, so in that case, researcher needs to have some idea with regard to the scales of measurements, which may be nominal, ordinal, as well as interval or ratio scale of measurements. So one thing that needs to be borne in mind is the nominal scale of measurement, it does not have order, nor does it have equal distance. So one fine day when the data is collected by the researcher and it's keyed in, he might code gender as 1 and gender. Males may be coded as 1 and females may be coded as 2. It's like numbers, but these numbers do not have any meaning. It does not have any order, nor does there exist equal distance between those numbers. If that's the case, then it is called as nominal scale of measurement, and accordingly it will have different forms of analysis for nominal scale of numbers. So the usual analysis that we conduct cannot be applied to the data that forms the nominal scale of measurements. When it comes to the ordinal scale of measurement, a simple example, when we go to the shopping mall after we purchase and when we are about to pay the bill, and in the billing counter, they usually ask us to give the feedback. So when we give our feedback, we usually know that, say for example, if there are options such as strongly agree, neutral, disagree, and strongly agree, then it is understood that strongly agree is better than agree is better than neutral, and so on. So we know that there is some order, but we are not able to quantify the difference between these two characteristics. And so is in the case of pain as well as the severity of disease, which all comes under the ordinal scale of measurement. So interval scale of measurement, it does have an order. It does have an equal distance, but there doesn't exist a true 0 point. A simple example would be the temperature that is recorded. 0 doesn't have, is not that meaningful. 0 does not imply the absence of temperature, but it is a freezing point. Similarly, when it comes to the ratio scale of measurement, it has got all the characteristics, such as it has got order, it has got equal distance, as well as it has got a true 0 point. So any analysis, parametric test can be performed on the ratio scale of measurement. So once the data is collected, definitely the data has to be keyed in just to make the data look simpler and meaningful and useful for further analysis. And accordingly, the data is reduced into a single number using the various measures of central tendency. But mind it, one needs to be very careful. We have the data on gender, which is numbered as 1 and 2, 1 for males and females as 2. It looks like numbers. So if you were to key in this data in the system, and if you ask the software to calculate arithmetic mean, it definitely calculates the arithmetic mean and gives us a value. But the softwares do not have brains. You key in, it directly gives us an answer. But we need to be sensible enough to know whether the data that we have fed in into the system is capable of calculating the arithmetic mean. Definitely not. So for a nominal scale of measurement or for an ordinal scale of measurement, arithmetic mean cannot be made use of. Then coming to the median as well as mode. Whenever there are extreme values in a given distribution, then it should not be represented in the form of an arithmetic mean, but median and mode can be used to represent the measure of central tendency. So along with the measure of central tendency, one needs to represent the measure of dispersion as well. So it has to come side by side. Along with mean, standard deviation has to be mentioned. Along with median, it is not the standard deviation that has to be mentioned, but it is the quartile, interquartile range that may be represented. So then, given any distribution, it could have the same mean value as we see over here. In the first case, all observations are 7. So that means most of the observations concentrate along the value of 7. That means the mean is equal to 7 and there is no variation in the data. That is why the standard deviation is equal to 0. In the second example, the slight variation in the observations, it slightly deviates from the observation 7, but still, if you were to calculate mean, it turns out to be 7. The slight variation, so standard deviation is 0.63. Whereas in the third example, we will see that there is lots of variation in the data, but still, if you were to calculate the measure of central tendency, it would turn out to be 7. But since there is lots of variation, standard deviation turns out to be 4.07. So even though the means are same, it may not be that the standard deviation also are same. It all depends on the variability in the data. Coming to the coefficient of variation, which can also be adopted in some of the scenarios wherein we have data to be compared, but with different units of measurements. We may have data which is expressed in terms of centimeters, and we have another group which is expressed in terms of kgs, 2 different units of measurements. But you can say which of these 2 groups are more variable by making use of what is called as the coefficient of variation. So this was all about the descriptive statistics. When it comes to inferential statistics, we have what is called as testing of hypothesis or the test of significance. Imagine we have a number of patients suffering from a certain disease. So what we do is we divide these patients into 2 groups, the ones receiving treatment A and the other group receiving treatment B. So there may be 50 patients in one group, 50 patients in another group, which would be scientifically decided on. And then once the treatment is given, these patients may be followed up. And maybe in the first group, the patients would have taken almost 6 weeks to get relief from symptoms. And in group B, the patients would have taken 7 weeks to get relief from the symptoms. So we observe that there's a difference of 1 week between these 2 groups. And now we are interested to know, why is this difference of 1 week seen between these 2 groups? Is it because of chance, or is it because of the influence of an external factor? So whenever we encounter such situations, then it is this test of significance or the testing of hypothesis that needs to be made use of. So first, we need to state what is called as the hypothesis, which are of 2 types, the null and the alternative hypothesis. So in the null hypothesis, which is denoted as H0, we usually state that there is no significant difference. And we say that there is no significant difference in the outcome or the parameter of interest between the 2 groups. Whereas in the alternative hypothesis, we say that there is difference in the parameter of interest between the 2 groups. So here we have an example with regard to the musculoskeletal disorder, which most individuals tend to have because of prolonged sitting. So in the null hypothesis, we can say that there is no significant difference in the mean pain score at follow-up among patients receiving treatment A and treatment B. So we've used the word no significant difference. Whereas in the alternative hypothesis, we state that there is significant difference in the mean pain score at follow-up among patients receiving treatment A and treatment B. So now, when we state such hypothesis and when we try to solve such issues, then there are some problems that can creep in. That is, in reality, the hypothesis that we have stated may either be true or it may be false, which needs to be tested on the basis of the sample of patients that we get. So we may come to the conclusion of either accepting the null hypothesis or we may come to the possibility of rejecting the null hypothesis. So when such conclusions are tried to be drawn on the basis of sample, there is the possibility of committing such errors. And one error is the error in rejecting the null hypothesis when it is actually true. And the other error is error in accepting the null hypothesis when it is actually false. And these are known as type 1 and type 2 error. So the probability of committing this type 1 error is known as level of significance. So maybe if we fix the level of significance at 5%, that implies that we are, as researchers, we are 95% confident that we are not going to commit any such error of rejecting the null hypothesis when it is actually true. So these are the various steps in testing of hypothesis, wherein first the null hypothesis needs to be stated, then the alternative hypothesis, then, as I've already mentioned, choose an appropriate level of significance, that is the probability of committing type 1 error, and then decide on an appropriate test statistic depending on the objective of the study and depending on the number of individuals included for the study, which is compared with that of the tabulated value, and accordingly we accept or reject the null hypothesis and decide whether the difference observed is due to chance or is it due to the influence of an external factor, where the external factor over here is the type of treatment that is provided. So accordingly, we make use of the various tests, such as it could be the Z test or the T test. So in case if the T test is used, it could either be the unpaired T test or the paired T test. Unpaired T test is usually called as an independent T test, which is used to test whether there is any significant difference in the outcome measure because of two modalities of treatments. So one group is given one modality of treatment, another group is given another modality of treatment. So the individuals in these two groups are independent of each other. So the test that can be applied over here is the unpaired or the independent T test, whereas a paired T test is one wherein an individual is assessed before and after giving some treatment to check whether that intervention is effective or not. Of course, all these assumptions have to be checked before applying those statistical tests, which is known as the parametric test. That is, the observation should be randomly selected, quantitative in nature, normal distribution, and existence of homogeneity of variances. And of course, the test for normality has to be checked as well whenever these parametric tests are used. In case if these assumptions are not met, then an appropriate non-parametric test can be made use of. And also there is what is called as a chi-square test. So usually researchers get confused with the chi-square test and the correlation analysis. So chi-square test is usually used when the data, it could be nominal in characteristics or it could be ordinal in characteristic. So the researcher may be trying to find, say for example, whether there's any association between smoking as well as development of a disease. So the smoking status may be smoking yes, smoking no, exposed and non-exposed, which is nominal in characteristics, and the development of a disease, which is the disease present or absent. And there may be also other scenarios wherein the variable under consideration may be continuous in nature, but the researcher feels like categorizing them into various categories, such as the weights may be classified, which is continuous in nature, can be classified into various groups, such as between 40 to 50 kgs, 50 to 60, 60 to 70, and more than 70 kgs. So you have various categories over here. And then on the other side, we have diabetics as well as non-diabetics to check whether there is any significant difference in the proportion of diabetics and non-diabetics with regard to the weights of a group of individuals. So here a contingency table may be prepared. So usually in a chi-square test, what we have is we have the data which is categorized into various categories, and we try to find whether there is any association. It is not correlation. We are not trying to find any correlation. Our data is not continuous in nature. Our data is not measurable. But these are classified into various categories, and we have the cell frequencies over here. So that is why we tend to use the word association and not correlation. So the procedure would be same. We state the null hypothesis, alternative hypothesis, check the calculated value with that of the tabulated value, and accordingly we give the conclusion. Now, when it comes to correlation, you have the data which is measurable in nature, such as heights, weights, blood pressure recordings, etc. So here we are basically trying to find the strength of relationship, or the strength or the associate or the relationship between the variables. So to ascertain this, maybe scatter diagram or Karl Pearson's correlation coefficient or Spearman's rank correlation coefficient may be used. So scatter diagram would be a visual representation, whereas to exactly quantify the amount of relationship, depending on whether it is measurable or whether the data is ranked, one may either make use of Karl Pearson's correlation coefficient or the Spearman's rank correlation. So this is how a scatter diagram would look like, and the researcher gets an idea whether the two variables are positively correlated depending on how the points are spread along the XY plane. So if the value of R is equal to 0, it implies no correlation. Greater than 0 implies positive correlation. Less than 0 implies negative correlation. However, the values lies between -1 and +1. So as I've already said, in a PAT test, we are trying to test whether there's any significant difference between two dependent groups. An example would be the effect of alpha blocker on urinary flow rate, wherein the intervention would be given. Same individuals are assessed before and after the intervention to assess the Qmax, or the maximum urinary flow rate, before and after the intervention, to check whether there is any difference or whether there is any improvement in the urinary flow rate among the same participants after the intervention. There is one more test which is called as analysis of variance, which is almost similar to that of a independent t-test. That is, two groups are independent of each other. Then we use the independent t-test. But when you have more than two groups which are independent of each other and they need to be compared, then it is the analysis of variance that can be used. And of course, various assumptions needs to be met. So along with correlation, of course, the regression analysis also can be made use of. If the variables are continuous in nature, then it goes under simple regression. Many variables are there, it goes under multiple regression. And if the dependent variable is dichotomous, such as the responses to a treatment, yes, there was success or failure, just two responses for the independent variable, then it goes under the logistic regression. To continue with the analysis of variance, if the researcher is interested to know whether there's any significant difference in the mean maximum urinary flow rate among patients receiving different treatments for BPH, there may be more than two treatments for BPH. And if the assumptions are met, then it is the analysis of variance that can be used. So then, to analyze the data, various statistical softwares are used, such as SPSS, which is a little expensive, but it gives good results, provided the researcher knows as to which test has to be applied in a given scenario. Of course, Jamovi is free of cost, and there are other programming tools that can be used, such as R programming, MATLAB, Stata, or the Python that could be used. So whatever it is, there are tests. When we feed in the data in the softwares, we get the results. But we as researchers, we need to know whether we are using the right statistical tool, whether the data that we have meets all the assumptions that can be used, that can be use to consider a particular parametric test. So if the assumptions of a parametric test is not met, then one can make use of what is called as the non-parametric test. Thank you.
Oh, thank you, ma'am. Thank you, ma'am. So we'll have now, because you have made all the three talks together, let me first invite Dr. Arvind Ganpale for giving his expert comments on framing the research question and how it is important for the residents to initiate the study which they have in their mind. And followed that, I'll just request and invite Dr. Pankaj Maheshwari to give his insight as Associate Editor of Indian Journal of Urology. How important are all these statistical design and what is the easier way to negotiate while doing a clinical research? Arvind, over to you first. Arvind?
I think till Arvind joins it, madam, I really need to compliment you. It has been a fabulous session. The way you have compiled everything, you have simplified everything, and all the examples that you gave were from urology literature. So it was a big learning experience and thoroughly enjoyed it. I have made lot of notes of your presentation and I really loved it. And I'm sure students must have learned a lot from what they have heard today.
Thank you, sir.
Sir, as Arvind is not there, I would just want to, is Arvind there, sir, or should I continue?
No, sir, he's joining. He got disconnected. Please go ahead.
So to the students, I'll say that, you see, research is extremely important. We need to be, say, looking for questions that can be asked and looking for problems that can be solved. This can only be possible if you are observant in your day-to-day practice, observant in what you do in the ward work, observant in what happens in the operation theater. This will entail a lot of reading, not only of the basic sciences, but also of the recent literature or articles that get published. Keep your data, assess your data, see what difference simple things in the day-to-day practice make in the patient's results. And don't try to do landmark studies to begin with. Try to look at simple problems. Say problems as early as, say, time of catheter removal, a balloon inflated in the catheter, and what is the impact of that on patients' lower urinary tract symptoms. So start with small problems and try to assess how your day-to-day things impact these small patients' results. So being observant, being regularly reading, assessing your data and maintaining a good data would be very, very important. Once you have a proper question in mind, then deciding the type of study it will entail, whether it is feasible in your 2.5 years that you would be there doing your residency. Is the study ethical? We don't need to harm the patients. That's the most important thing. Do we have the cost to manage this study? And do we have the sample or the number of patients that we can really treat in our given time frame? So look at smaller problems, look at day-to-day problems. It is extremely important to write. You see, everybody can do a ureteroscopy or everybody can do a small TURP or even complex robotic cases. But to be recognized in our own society, only your publications and your research work will help you get recognized. Nobody can take it from you. Invitations in conference may have a lot of other reasons other than your scientific profile, but your publications are completely your effort. And with one more important thing that I'll want to tell you is that remember that there are nearly 220 journals in urology. These are pure urology journals. Add to that para-urology journals like uropathology, uroradiology, uroanatomy, uropharmacology. The number of journals will go up exponentially. If we consider that every journal needs as small as 10 manuscripts every month, there is a need for more than 2,000 manuscripts every month. So if you have an idea, there would be a journal that will be willing to accept it and willing to publish it if you can pursue it well and present it properly. Don't concentrate only on case reports. Case reports don't really give you that much advantage both to your CV, to the journal, and to the scientific community overall. Doing small studies is important, and concentrating on small studies is really important. As far as the statistics part is concerned, once you have the data, then there will be people who will be able to help you as to how to analyze them. Your role will be predominantly to do the proper sample calculation, to do the proper tabulation, to maintain ethical and correct data. And then there will be many people in statistics department or expert biostatisticians like Madam who can definitely guide us when we have our data as to how that data can be presented. So let's not go into the intricacies of the statistics at this time. Let's go into the issue of say looking at data, maintaining data, and seeing what we can bring out of this data. I think, sir, anything else that we should be talking? Arvind, if you are there, you could take over.
When have you joined? I'll just call him. But Dr. Pankaj, what you are telling is absolutely very important. How I think whenever they have any study in their mind, when they have got all the question in the PICO format, and once they have collected at that is the point they should be looking with the help from the statistician, and who usually they help in identifying the number of subject to be studied, the sampling, and probably the way how to collect the data and how to keep it properly uncontaminated and in the Excel sheet. And it is not that you have to just start the study and at the end you just go and take all the data to the statistician for the help. No, it has to be sure that whether everything you are putting everything is correctly interim results with the help of statistician. Though it is not our field, but there are few amongst us who are very good, but not all are very good. And these are the things which need a little more in-depth. This need an expert analysis, and probably the help thought out at the beginning, in between, number of times, at the end becomes more relevant and important.
True, sir. I 100% agree that it is no use just randomly collecting data and then seeing that all the effort was futile.
Yeah.
To properly plan the study is important. But when you are looking at small impacts that your day-to-day things make, then probably just collecting data and analyzing it retrospectively works. But if you want a good scientific study, then involvement of biostatistics from day one and during the study becomes extremely important.
I'm just calling him again to just find out whether he'll be able to connect. Actually, he had another presentation in online in one of the African conference. Oh. So that time was, I think that time was a little earlier than our timing, but still I'm just getting in touch with him. If you are not able to connect to him, I think we'll invite Dr. Jinil to say a few words. Dr. Jinil, are you there?
Yeah, I'm here.
Yeah, please, sir. Your comments on...
Yeah, first let me congratulate Madam for the excellent talk. She has simplified the entire subject. It is very difficult in statistics, especially for surgeons. So basically, a few things I want to comment is the issues usually we face when we are planning a study. What we find among students are when they are doing a study, first of all, as Madam rightly told, the feasibility, whether it is innovative, the finer aspects they will not look into. Then finally, after they make the study, they find that this is not acceptable to majority of the journals. There is one problem. A majority of the papers, so they use some questions which may not be relevant or not innovative, already studied by others. Just to make a study, they start the study and finally end up not being able to present in a good community. That is one issue. Most important issue in our community is actually we are not properly collecting data in a standardized way. So after some time, if you want to have a retrospective, we find that more than 50%, 60% will not have all the data points entered. And majority of our centers, we don't have a dedicated person. So the person, one day, one person will be entering, another person will be entering later. So there won't be any uniform entering of the data unless it is monitored periodically. So these are the basic issues because of which we are not able to finally analyze the data and come out with a proper paper. Either we are not doing a serious study or we are not properly collecting the data. Only if these two are there, then it can end up in a good paper. So unless we are starting from initial aspect, then what happens is actually we start the study, we analyze all the data, and finally when we analyze, then only we ask what is our actual question is. So we have to frame the question initially, then find a statistician, set up the proper methodology and how to analysis. Then we have to analyze. Otherwise, what happens is all the effort put initially at the end go wasted. So all these mistakes has to be corrected initially to come up with a good study. Any comments, Arun?
Yeah, no,
Thanks,
very
madam,
well
for
said, very said. I think this is the way, as you as a chair of clinical collaborative research, you are also promoting the same idea. It's just making inculcating the good research habits or good scientific habits, which should I think should be the primary focus for a resident who is coming in. Because what is important is the point you made, or point Dr. Pankaj made. Whatever is encrypted in your name, any journal, especially the Q1, remains forever for generations to read and see and remember you. The rest, everything will not follow. So this is to do that, to get into that, you need to do some study, you do in a proper way, and get it published. And publish, there's no shortcut. Whatever experts like you, Pankaj, and madam has spoken is everything has to be followed in principle and in practice, and that's how the smaller attributes, the smaller habits, how to put a data properly, how to review, how to see that what you have missed, so everything falls in place. So Dr. Arvind has having power failure in his town, and because 5G is not available, he is unable to connect from his phone. With this, to wind up, I'll convey thanks to Madam a lot, because she travels to Mangalore every day. For our session, she has stayed, and she'll be driving back to Mangalore. And thanks to Dr. Pankaj, Dr. Arvind, and Dr. Sanjay in absentia, and to Dr. Jinil. And with this, I'll invite Dr. Chandraman Vati, Honorary Secretary, to place his closing remarks, and then we'll sign off.
Yeah. Thank you very much, madam. Very crisp and presentation. And I also thank Dr. Pankaj Maheshwari, sir. Though he has a lot of private practice, he still writes papers, and he is the sub-editor, and he reviews the papers, most important. Even though I'm having clinical material, now I have tied up with the statisticians and some of the people who are writing the papers. At least I am happy that yearly 2-3 papers I am able to write in pediatric. So if you try and collaborate with people whom you can progress, it is better. If you cannot do it, at least I have put now one statistician so that they are entering data. At least I have pediatric papers getting published. So with this, I wanted to, the youngsters, don't give up this. Keep trying, as Pankaj Maheshwari told, one or the other general will keep on correcting. Ultimately, one accept. So with these words, I thank once again Dr. Arun Chawla, sir, for taking pain. And in fact, he was telling that one more program we have to do, Chandramohan. We will definitely do, sir. And for all the audience, we are also doing physical meet at Chennai. Stanley Medical College Urology Department is conducting. Very important speaker by suggested by Dr. Arun Chawla, sir, are coming from Chandigarh, who are talking on artificial intelligence in relation to the research. Please don't miss. We will send the link for registration. It is nominal 50 rupees, 100 rupees charges. So please join on Saturday and Sunday. Physical session on 20th and 21st. Thank you once again, all of you, on behalf of ASU. Thank you. We will conclude the session.
Thank you. Thank you. Thank you. Good night, everyone.
Thank you, sir. Thank you, madam.
Thank you.
Pleasure attending. Thank you, sir.
Thanks for bye-bye.
Bye-bye again.